Give me a minute. Okay.
Yeah, take your time.
Okay. So question number 1.
Mm-hmm.
Here it is. Clinical presentation.
Mm-hmm.
So from the clinical presentation, we found that patient had intermittent abdominal pain after she drinks wine. Then patient had a past medical history of EBV.
Mm-hmm.
Also a lymph node.
Mm-hmm.
Then patient ESR and CRP was elevated, and also neutrophils were elevated.
Mm-hmm.
Then, so now, and the next question is pathologic finding. In pathological finding, we found that they have this histological examination reveals that Reed Steinberg cells were elevated and CD30 positive. Here, this one.
Perfect. Did you find it interesting that she has pretty advanced disease but didn't have really any other symptoms?
Yeah, she didn't have the B symptoms, weight loss, night sweat, and fever. She wasn't complaining of those symptoms.
Yeah, so in a small subset of patients, unfortunately, this disease can be very insidious because patients won't really have any other symptoms except for, maybe a node, and then also the fact that she had a recent flu-like illness is also pretty common. Because again, once it's affected potentially bone marrow and other parts of the immune system, patients start having an impaired response to infection. So that's perfect. Thank you. That's awesome. All right. So another team, can you take the next question? Who would like to help us out? I don't want to have to call on teams just because there are a few teams who don't have very many people right now. So I don't want to set them up for an uncomfortable scenario. So if another team could please help us out, that would be great.
Sure.
Yay, thank you.
So this is question 2, right?
Yes, question number 2. And after you answer it, please let us know kind of what literature sources you found and kind of walk us through how easy or difficult it was to get the answer to this question. Awesome.
Unmute. Okay. Let's see. So explain how EBV increases risk of HIV. Okay. So basically, it seemed like based on what we found, it has its own oncogenes that it expresses, and it goes around and it infects your B cells, and it puts that gene in your B cells. And so it basically turns your B cells into lymphoblasts, which, if, of course, the right step of things goes wrong, then it turns them into a tumor, and then they start dividing and uncontrollably.
Awesome. That's awesome.
But as far as our source, we have that one, and it's really recent, but we feel like we're not entirely certain that it's actually a primary resource. Most of the ones we found, especially from the last 3 years, they're all reviews or they're a meta-analysis.
Yep.
So the one we found, we think, is a meta-analysis, which we ended up rolling with because I went through all like 180 references that were attached to this, and none of them were like primary studies. They were all either reviews or meta-analysis themselves, or they were really old. So
right. And so one of the reasons I actually asked this question in this particular way was I knew it was kind of going to be a trick question. Not that I'm trying to be tricky, but this is a common problem that we face when we're looking up the answer to like a question about a disease state, for example. it's really hard to find primary literature that gives you a complete picture of what a mechanism is doing from a disease perspective, right? So if you think about the way science attacks a question, it's usually a tiny little piece of a larger question. So the question about, how does EBV increase a risk? That's an overarching question. There are probably multitude of different things that have to happen, particular strains of EBV that have more oncogenic activity than others. There's probably, potentially even some cell surface markers on B cells that may, if they're overexpressed in some patients or they have other kinds of genes that could be turning on or off. There may also be some interaction with tumor suppressor genes being inactivated, or, again, the concept of the double hit. So the idea behind this question was really, you're right, sometimes there just isn't primary literature. And so a review article in this case, when you're asking a question like this or trying to answer a question like this, is probably going to be your most helpful. So primary literature, if you can find something where there is maybe a particular study that someone figured out exactly mechanistically how this happens, that's pretty unusual. This is great. And the nice thing about this particular resource that you pulled is that it's very recent, because the association has been known for a while about EBV and lymphomas, just like HPV and head and neck cancer, cervical cancer. That's been known for a while. What's been a little bit harder for us to figure out is really that, is it just one or two oncogenes? Is it a series of oncogenes? Again, is it related to strain, et cetera? So we're still trying to figure that out. So that was awesome. Thank you. I appreciate that. Did anybody else find it challenging to find primary resources? Was anybody able to find a primary article, or did pretty much all of you default to a review article?
Review article.
Yep. Yeah, excellent. And so I think if you're in this situation where your preceptor says to you, asks a question like this, and you say, there's not primary literature, at least you can say, there's not primary literature available that really answers this question, but I found several meta-analyses or review articles that really provide a nice picture about how to think about this particular question. So, that's a perfectly acceptable answer. Awesome. Okay, so let's move on to the next one, because this one's a little bit more complicated. Is there a team who would like to kind of attack this, or at least part of it? Question number 3.
My team didn't finish, but we can show you.
Yeah. Sure, that sounds good. And then if wherever you guys didn't finish, we can have another team who has take over.
Okay. We just didn't finish the last, which one to recommend. So
okay. That's fine.
Okay, can you see my screen?
Yes, perfect.
Okay, so this was the article that we went off of.
Mm-hmm.
So basically just compared brentuximab with bleomycin.
Mm-hmm.
And then it's pretty recent. I think it was done in 2017.
Yeah.
So anyway, we're finding that there is a lot more adverse events with the monoclonal antibody, which we kind of already figured.
Mm-hmm.
So for example, with the anemia, there was more than that one,
Mm-hmm.
but the bigger one was with the febrile neutropenia, where it was 54% versus 39%.
Yeah.
And then we found there's a higher immunogenic risk with the MAB.
Mm-hmm.
But we did see this part that I'm highlighting. We did have that finding. So when you called this back, we were trying to figure out, like, is it worth giving them a ton more toxicity versus like giving them survival? So we were trying, and then we were also trying to find the cost too, because like we were trying to find the cost, but we just know that monoclonal antibodies are like historically a lot more expensive. So we're trying to figure out like just cost and safety, like how much can you give when you're trying to like prove which one's better or not.
Yeah, that's awesome. No, that's a really, really good start. So when you were looking at the brentuximab compared to the Bleo, were you able to see what the incidence of like pneumonitis was, for example, in Bleo, since that's like the major dose limiting?
Let me grab the table.
Oh yeah, perfect. Tables. See, they've come back to haunt you guys. Yeah.
Emily, was it table 4? I think it's, let me see. There was a table that had that exact one. Let me just find it really quick.
Yeah, it's probably in the, here we go. Adverse events. Okay.
And there was actually a bigger table in we went to like the trials.
So yeah, you see neutropenia. Okay, peripheral sensory neuropathy, which is from that vinblastine.
So I'm not seeing pneumonitis here.
Interesting.
But I could go to, so this is the actual trial data.
Okay.
Sure.
Yeah, and if you scroll down, actually, I think I saw it. Pneumonia. Sometimes pneumonia and pneumonitis are mixed up. Should be by
pneumonitis right here.
So that's PCP pneumonia. Let's see. A lot of pneumonias, right? So which could be again related to pneumonitis. Surprised I don't have pulmonary. Maybe it's under P, which would make sense. So yeah, if you keep scrolling down. A respiratory. Here we go. Okay, pneumonitis.
So this side is the MAB, and then this side is bleomycin.
Yeah, so that's a pretty substantial. So what's interesting about this too is that you kind of, so I see that they've blown out these individual like different kinds of lung toxicity or whatever, but if they kind of put everything together, which is what they should do to look at kind of all-cause respiratory disorders from the Bleo versus the brentuximab, the Bleo would definitely have a much greater percentage cumulatively, right? And so here's the problem. You guys mentioned cost. So here's the problem with looking at cost. So you're right. Brentuximab is substantially more expensive than Bleo. Bleo's been out forever. It's an old drug. And the other thing is, like, because it's an old drug, we understand how it works and we pretty much can anticipate the different side effects. Pneumonitis is a little bit more of a black box. We're not always sure exactly who it's going to happen to. The problem is that pneumonitis is also very expensive to treat. And so one of the things that many of us try and figure out is the cost of the drug going to mitigate the cost of adverse events that can happen because of a different drug? And, I don't know that we have that data specifically, which is one of the reasons why I added in a question about like quality of life to see, because sometimes in quality of life data, they also look at like not just the cost to the person specifically, but also the cost to the system, and how some of these toxicities may decrease their like enjoyment of life and also result in hospitalizations and things like that. So there may not be a good answer to this, but based on like from a pulmonary toxicity perspective, we know that Bleo is far more pulmonary toxic. But you're right that the febrile neutropenia, so that was febrile neutropenia, right? Not neutropenia by itself.
I can give you a better picture on this one. The one that they showed in the trial.
Oh, wow.
Yeah, so it's 17% versus like this 6.5, which is a lot compared.
That is a lot. So what, do you guys remember what risk category would you categorize that? And anybody can help out if you don't remember. Would you consider that like high, intermediate, or low?
Oh, high. So
this, the febrile neutropenia, it would be intermediate, right? Because high would be greater than 20%. So 10 to 20% is considered intermediate. And then if you look at ABVD with the just the bleo, that would be low because it's less than 10%. When you were reading the article, did you see if they dose delayed or if they delayed patients because of febrile neutropenia, or did they give them like growth factors support at all?
I can look at that and get back to you. I did.
Yeah, sure. No, that's totally okay. And the reason I asked that is because we also know, factoring into our decision, that ABVD tends to cause a lot of neutropenia, but we don't necessarily delay them. If they get febrile neutropenia, though, that's a little bit different. If you have a fever, we have to delay you, which can be problematic if we're trying to cure you too, right? Mm-hmm. But there's also that risk that if we give growth factors, it could potentially make the pulmonary toxicity worse with bleomycin. So that would be another thing that I would consider. Okay, if the brentuximab causes more febrile neutropenia, but it doesn't have the pulmonary toxicity risk if I give a G-CSF, then, does that mitigate the risk of bleo from the bleo, or the risk of pulmonary toxicity from the bleo, and should we just go with brentuximab? So these are kind of some of the questions that we end up trying to figure out on a day-to-day basis, because we don't always have all the data available. Awesome. Thank you so much. So for another team, did any of you finish and were able to get to kind of the last question about quality of life data, if you found any cost, and then kind of what you think in terms of switching to brentuximab? Or did most of you kind of get stuck in that last spot?
Dr. Leva, we were stuck over there, but I just want to add to Morgan's.
Yeah, please.
What we found was without the prophylaxis, it was about 19%, but once you added the prophylaxis, it dropped to 11%. So just wanted to throw that out there.
Yeah, please. So that was for patients who were treated with the brentuximab.
Yes.
Okay, perfect. And did they say what they gave? Did they give was it G-CSF per investigator choice, or did they say we used pegfilgrastim or?
I actually don't remember exactly what it was, but it was a GCS.
Awesome. Yeah, no, that's perfect. And we normally, even in protocols where you're doing a clinical trial somewhere, often for antiemetics and febrile neutropenia prophylaxis, it'll say per investigator's choice. And that's often just based on guidelines or what's on the formulary for a particular institution. So that's a really good point. Thank you for bringing that up, because then that allows somebody to continue on the drug, right, without being dose reduced or have their drug held. Awesome. Okay. Anybody want to weigh in on the last question or the last part of the question? Was any group able to finish that? Because if not, then I will let you guys finish that out and we'll wrap that discussion up tomorrow. Okay. I will assume that everybody was almost done, but not quite. So that's fine. I think so far you guys did a great job on this question, and it's a fairly complex one, right? We don't really have all the right answers or all the answers at all. So we'll plan on kind of wrapping up that last question. So please look into more of the toxicity, the cost, the quality of life data if you can find it. And then also be prepared to have a decision about, if you think that, the choices are really, yes, we can switch for Bleo, in all patients, or, maybe we just do it for some kinds of patients and then figure out who those patients are, or no, they really don't have the same function and they shouldn't necessarily be swapped out for each other. So those are really kind of the three options that we can choose. Excellent. Okay, so are there any other questions? Because I want to make sure that you guys really are able to finish this out. Okay, so the plan, I actually have a meeting at noon that I'm going to have to jump onto, but after that meeting is over, I'll open up office hours. I'll post the IRAT for tomorrow and the practice quiz. And then I'll post a couple of things for Thursday. It's going to be very low key. I still want you all to show up, please, if you're able to, because it'll be our last day. And I'm also trying, I can't promise, but I'm trying to write the last exam and get it done before Thursday, so that potentially we can just have like a short discussion about and then I can go into the exam review, get it done.